Welcome to the NK Active podcast. So we are now going to chat about what is rehabilitation and what do we mean by it. So firstly, what is rehabilitation? So we sort of paraphrased from the World Health Organization, or WHO, as people may know them as. So it's using a set of interventions designed to optimize function and reduce disability in individuals with health conditions, acute or chronic, in interaction with their environment. So essentially it's trying to restore health through exercise and training, and it's something that it forms a massive part of what we do at NK Active. We can chat about how we do that later. So David, sort of who benefits from that rehabilitation process?
I think everybody that comes through the doors is going to benefit that, because we individualise it to their goals and their needs to get them back to their pre-injury or pre-condition levels of activity.
And we talk about injuries from the physical element of it, but do we find that doing a rehabilitation has any impact on sort of the environmental, the mental health, the well-being aspects of people's lives?
Oh, definitely. Even a committed rugby player or skier getting back to the things they were doing before can have a worry and a fear about that, and long-term chronic conditions, they can be really difficult to manage and have a very big effect of, will this ever change? Can I get over this? What am I going to be like? And it's very normal and what would the right word be? Well, for anybody to be worried about their injury. Are they going to be worried about work and their job and the future? Are they going to be a bit low in mood if they're missing something? So it's just where on the continuum their anxiety or their mood takes them, really.
And are there certain, you sort of mentioned about anxiety and mood, are there any sort of considerations that we really need to take into account, I think would be a nice way to describe it, when you're looking at going through that journey?
Yeah, I think with talking to the person, it's very easy to get drawn into anatomy and tissue specific and the issues in the tissues, but those tissues are attached to a person who has thoughts and beliefs. And what's that person's background? What's happened in their family? What's happened in their injury history? If they've had a bad experience before, is that going to highlight their worries and fears? So digging in and getting a really good subjective assessment of the patient and where they're coming from is so important.
Okay. And then Charlie, if we then move on to benefits of that rehab process, what would you say that they are?
I think it's that ability, as David was mentioning, about being able to take a patient and holistically approach kind of what is it that they want to achieve. So it's providing them with that ability to, I guess, really set out for them where their baseline is and where their end goals are, and that will vary. So if you have conditions such as stroke, or if you've got a neurological condition, then you've been on a bit of a journey and process already. So rehabilitating maybe to do the very basic things again, which is to make a cup of tea, to stand for a period of time, to be able to go collect the kids from school, to be able to start to learn to speech or return to work. So I think it fits in with actual societal life and being able to become part of a community, and that again will affect kind of emotional, physical and social well-being. So that's a lovely benefit that we do see with rehab. I think it's around the lines of, it's not just necessarily injury, it can be around about reducing the risk of disease deteriorating, supporting those that are going through natural processes like aging, and being able to allow them to have the capacity to do more or do more of the things that they love for a longer period of time. I think it also has the ability to be a positive tool in being able to give people more opportunities to do more of the things that they like in terms of activities and interventions. And sometimes it's used in adjunct to others, such as medicines or surgery, to be able to improve that person's outcomes, to be able to get back to doing what they love to do again.
And you talk about sort of reducing the effects and risk of long-term health conditions. And obviously we see a lot of people who have long-term health conditions. So, and the question that always people always the goal, that people always come in with to begin with is, I want to be pain free. Is pain, do we think, the right way to measure that outcome and whether rehab is successful or not?
So I think it's a bit more complicated than that. I think pain does play a part in the conversation. I think it's also about understanding where they see themselves. So through rehab, you tend to find that may be the first initial goal, but there'll be others that they'll want to aspire to. So it's very much thinking about how do we break it down to get them there. So I tend to very much focus on ability to function, ability to manage discomfort, to know what some discomfort is that can be normal. So things like delayed onset muscle soreness is something that is relatively normal when we're going through a rehab process. If muscles haven't been worked or are going out of their capacity in a safe way, then we are going to get some reaction. Those tissues are going to change somewhat. So it's meeting those expectations, being able to provide an explanation of what we are assuming will happen, and then providing that patient with strategies on how to manage that, when to know what the warning or flag systems are, and then how to work with that, I guess. So pain has its place, but I don't think it should be the whole focus of a rehab activity. It's a mechanism that the body has to warn us to things that may be arising or working or stimulus. So it's just understanding for that individual what that looks like, and then working with that to then work out, right, what exercises do they need to be modified? Do we need to increase the intensity? Do we need to maybe go to band work before we start to introduce load? So it's accommodating and being mindful of it, but not letting that determine whether you're doing a good thing or a bad thing.
Yes. And I think you talk about pain and structures, you briefly sort of spoke about there, and we know it's not that black and white. We know if you look at the work, I think Ebony Rio has done some work, and a lot of it is around tendons, and Karen Sivernagel has as well. We know that when you try and correlate structure to pain, it's very difficult. There is a study that's been published. I can't remember. It was quite a large cohort study looking at scanning multiple knees, and they found that people had different severities of arthritis in their knee, but the severity of arthritis you have in your knee doesn't correlate to pain on a reliable and sort of repeatable basis. So I think that's why when we focus on pain all of the time, I think there's possibly a risk of heightening that pain as well. Whereas I think what we try and do is say, look, let's focus on function, let's focus on doing stuff. And actually we tend to find the more you get people doing, naturally the pain and sometimes settle. And it's also saying that if something hurts, that's not necessarily a bad thing. You're not always causing damage when something hurts. And you mentioned DOMS, that delayed muscle onset soreness, is when people are getting back to activities, people all get those muscle aches and pains. They haven't injured. That's just the body just adapting, saying, I've done something, not quite used to it. This is my way of saying, can you just give me a few days to recover? I'm fine, but I just need a few days off. So then that actually leads nicely into, we talked about pain not correlating to structure, but there's also, is there an element of, David, pain sort of being out proportion to the pathology that someone's presented? Because we are amazing, human beings are amazing creatures, but we are reliably unreliable. And the thing we always need to remember is that to the end of any rehab program, there is a human and a brain attached to that, which sometimes is wonderful. Sometimes it decides for a big spanner in the work. So sort of, if you can sort of just speak more about like what happens sometimes when you find these cases where the pain levels are really high, but they don't match the injury someone's presenting with.
Yeah, it's a really interesting area, because we've heard of sciatica, where someone has some issues in the back, but where's the pain? It's in the leg. And you ask them, have you got anything wrong with your leg, and why have you got pain there? Or people with chronic pain, long-term pain, and you ask them, have you heard of phantom limb pain? where someone hasn't got a leg and they still feel pain, and a leg they haven't got. And it opens up the conversation about how much tissue damage they think is related to pain. And the amount, there is just no correlation. And it comes down to people's beliefs about the understanding of the worse the injury is, the more pain they'll have. But then we can talk to them about things that they know. They know that they've cut themselves and go, oh, I'm bleeding, where did that come from? Or they know that they've seen a footballer or somebody feel like they got kicked in the shin and they've torn the Achilles tendon. So some big ruptures, some big issues, or someone felt a bump and had been bitten by a shark. And they go, yeah, I have heard of that. So things that we know that go on, that we can say are facts, well, actually, they don't fit with the more tissue damage equals more pain. And then you've got an interesting place because you've got a question, and where do you take that in their thought process?
And I think it's all about that context, isn't it? Like, reading the book this morning, that they gave the analogy of the author, one of the authors from the authors from in the book they were referencing, got bitten by an extremely venomous snake.
Yep.
And didn't know they got bitten by a snake until they looked down. They ended up in hospital and like come out of a coma and survived. But then a few months later, I was out for a walk and felt something again, and almost assumed that their pain was much higher because they'd got bitten by a snake. But actually, they just brushed their leg against a sharp rock.
Because it was a learnt behaviour that was life-threatening before. So we can learn that if we bend forward, the back hurts. We can learn that if we take a step, things hurt. And they're not related to tissue damage. They're learnt to changes in the plasticity, the neuromatrix in the brain. One thing leads to another, and there's a chain of thoughts and beliefs. I had a scratch there on the side of my leg. That was life-threatening. I need to protect myself from that. All the bells and whistles, all the alarms go off. Well, actually, it was a scratch.
Yeah. And you've said about it before in previous podcasts about the fact if you ask someone to pick up a 10-kilogram dumbbell, they may say, I'm not going to do that because it's going to hurt. You ask them to pick up their child in the car seat, so their lower limb and their back is doing the same motion physically, and it doesn't hurt. But then when actually you weigh that 18-month child plus the car seat, the chances are that will weigh more than that. But because it hasn't got that number printed on it, they think of it as different things. But from a physical aspect, it's the same thing. So to summarise that section up, as it were, can you sort of retrain the brain to then get yourself out of those habits?
Absolutely, and there are lots of ways to do it, and some of them have the graded exposure. If someone's a little bit anxious, no amount of education or practice is ever going to be enough. They have to do it and learn the experience. If you gradually increase, and gyms are very easy places because everything's numbered. We do sets, reps with weights. In life, when someone's carrying their shopping, someone's living independently, living on their own, how hard are they working? How much does their shopping weigh? How much does the washing weigh? What are they carrying upstairs? So there's things in life that aren't numbered like that. So the gyms can be very helpful, especially when we see increases. Well, we'll start with 1. How was that? 2. How was that? And we take people step by step through that process. Well, actually, 10 was all right. Well, would you be prepared to do 11? Yeah. And what is your response to that? Fact. You've learnt, you did it. And it's that anxiety. If you ask them, do you want to do that? They might say no. Well, where are you happy to start? Start there, meet the patient where the patient is, and then take them on that journey forwards.
Yeah.
I was going to say, I think that's a lovely way of saying that we have access to a gym, so that's our kind of playground, as it were. But actually, for some people going through the rehab progress, it will be in their own home or in their back garden, and that you can use items around the home to start that rehab process. For those that have stroke or Parkinson's or dementia, they're going to it will be subtly different tasks we're getting them to do, but the load and equivalents are the same. It's being creative and, I guess, working with the individual.
Well, you are certainly creative, Dave, when you come in, because when Dave started, the first thing he brought in was some backpacks. And it is literally like, I'm sat there with a patient going through a rehab program. I'm like, I need to add more weight plates. where are these weight plates gone? And he just shoves them in the backpacks, and it's sort of like, which will replicate people shoving shopping cans of beans or whatnot.
And it just opens up their mind to, oh, I can't
Yeah.
do this because I haven't got the weights. Well, here's a backpack. We're going to put weights in, but you can load it with anything at home that you've got. Maybe not your child or your
Well, you
animals.
don't. I have been known to sit there. I embarrass my wife because like I'm out there, I'm standing in a queue, and this is like when I used to carry my youngest in a baby harness, and I'll be standing there, and we'll say, Nick, what are you doing? I'm sat there just doing calf raises or something. Just thinking, well, I'm standing here, I might as well make use of some time. It's sort of, I've got extra weight because I've got a child attached to me, and it's So I think the other thing is that when you then talk about the benefits of the rehab, I think it's also then going through of, yes, we got the physical elements, yes, we've got the psychological elements of it as well, but it's also teaching people to have their own self-management and doing things themselves, and letting people let you take control of your own health and your own problem. Because at the end of the day, as we all say to anyone that comes into clinic, that it's not our pain, it's not our pathology, it's not our problem, it's yours, and you will do it yourself. We won't fix you. The body will do that. We just need to put it in the right environment and educate you on how to do that process. And I think that's almost the easy part.
Yeah.
The hard part is then trying to then explain, and the education process, and why you then need to continue doing this afterwards. Because it's that analogy of use it or lose it. You see too often, you hear people that come into clinic where they've done stuff in the past, they've got better, and all of a sudden, right, I'm better now, I'll stop doing it. And then 6 months down the line, the pain comes back. So then it's us then sort of educating people on the importance of, well, now you need to do a maintenance program to carry on doing this, to actually now make sure you maintain what you have spent all this time and effort in doing. And I think by that, you see a massive change in people that come into clinic in the way they look at things, the way they perceive. Like, it's almost like you hit the nail on the head where you said, I think I can't do this because it's going to hurt. Then when people leave, it's like they just do it and they say, if it hurts, well, it may hurt. It's not going to cause any major issues. I'll recover. It's fine. I'm just going to do it.
I think an interesting one for those is somebody who walks with a stick. Why do you walk with a stick? Well, I might fall over. Well, that's true. That's a fact. But they don't know. What if you didn't? What was the worst thing that could happen? Oh, it's not always the worst thing to happen. Have you fallen over? And what happened? Well, nothing. I felt silly. And it's worry about what might happen that holds people back. Let's put the stick down. Let's walk across the room. You didn't fall over. And it's taking them through those, guiding them through. And then the confidence and the realisation in them that their beliefs, well, I might fall over and the worst is going to happen. Well, the worst doesn't always happen. And we do drive cars and we do walk down the road and we do take risks, acceptable risks at an acceptable level. And we just help people through that and help them to see that there are other ways of doing things.
And that's very similar with our orthotics. So we may use that as a short-term interim to help offload a structure while we go through that rehab process of changing load, modifying activities, strengthening areas, looking at education, look at training ways. And then the orthosis will be removed. And it's that belief that you don't need them all the time. They're just there as a tool to do the thing that we need it to do for that short term, so that longer term you're able to manage and hopefully not need us.
You've just given me the idea of the next podcast is let's have a thrash out and review of what orthoses are, and because there are still some beliefs out there like you fit orthoses and that's it, they're a life sentence, but we won't delve into that too much, have we? I'll get on my soapbox and rant for an hour, so we won't do that. But I think we know with the rehab that studies have shown and suggested that you get that benefit from for that individual, but there's also that benefit for society. As David already said, like if you can reduce someone's risk of falling, then yes, that has a greater impact on that person, but then also then has a greater impact on a demand for them to need society to help them, on family and friends, on other medical services, which then, so you sort of think about this little thing of rehab and exercise has so many benefits, not just for that person, but everyone around or involved in their possible care. And it's almost like it's, I know we may be biased because this is our main our main passion here, but it is almost like exercise and rehab is almost a lot of the time the best drug that someone could prescribe you to get on, because we know it has so many benefits and it's backed up in the research with so many things. So if we then sort of moving on is, let's delve into deeper the considerations around rehab, Charlie. So what are the things that we really need to be mindful of? Because unfortunately, we're not robots. We can't give everyone 12 reps, 3 sets on the same exercise and everyone have the same outcome. Life would get boring if we'd done that.
Yep.
So what are the things that we have to be mindful of?
So we're always thinking of what is the, I guess for here it's looking at what's the diagnosis or what's the chronic condition or acute condition that we're thinking about managing. And so then it's thinking about what movement patterns or exercises do we may need to train or improve upon, and those subtle things. So in clinic, I may get someone to do a simple kind of bridge position to work on kind of glute work and core stability. But actually, the way I will do that, I can give 7 or 8 variations of that, because there'll be certain muscle groups or certain ways that I'll want to kind of enhance or work someone harder in order to do that. So I think first of all is being mindful of where is this individual on their journey of rehab, and making sure the exercises are challenging but not unachievable, because then that will sink in with looking at their motivation. So there may be, for some patients, I may do kind of what I call the quick wins. So very simple exercises that get them really keen to participate. So they've got that kind of building of self-esteem, that confidence, that ability to know that they're doing a good job. Some people like that positive reinforcement really quickly, but knowing that there's going to be movement patterns that are going to be harder to do. And that's just preparing someone to be curious, to keep going, to keep trying, that failing is okay, to not do something, and getting person kind of prepared, I guess, that not everything will go kind of in a trajectory that they would like, that it's going to be a little bit of a bumpy road. And I think that reflective of life as well, isn't it? It's that mental and physical preparedness of what's going to happen ahead. I do take consideration of time. So I'm very mindful of not setting really hard deadlines. And that has 2 aspects. That can sometimes be very pressurized for someone. I think in society, we live in a very deadline-driven routine. So being mindful of, yes, this is the end goal, but being mindful that time to take to get there may change, it may accelerate, it may take a little bit longer, is okay. And I think that consistent negotiation, that consistent reflection while a person's on their rehab journey with us is important to show where they've come from, but also where they're going to. I think as a rehab person who is guiding someone through, it's that ability to be mindful that the goals will change. The amount of times where it's just been, I just want to walk to the end of the shop, and then they've ended up signing themselves on for like an Ironman or woman competition, and you think they're 2 very different things. But again, it's then having that conversation, because actually the exercises and the training that they got you to do originally is very different from the training that I would maybe prescribe or give for someone doing a kind of a marathon type stage. So it's working really with that individual. I guess it's that ability to provide the person with space and time to be able to work things out. Like, I'm very privileged that when we do the rehab, it is about them problem solving. Although I like the challenge of that. It's also them working out how that fits within their routine.
Yeah.
And coming up with lots of strategies, I guess, and being mindful that they will try some and some will work and some won't.
So this podcast is starting to get quite long. So what we're most probably going to do is break this up into 2 parts. So this is the end of part 1, and we shall see you shortly at part 2. See you guys later. Bye.